amplification by stimulated emission of radiation. Okay. Light amplification by stimulated emission of radiation. It was in the year 1971 by stimulated emission of radiation. Okay. That Johnson and Weekman, they introduced lasers to endodontics. So it was in the year 1971 that Johnson and Weekman, they introduced the usage of lasers in the various fields of endodontics. They introduced lasers to endodontics. Now, lasers, they are highly collimated, coherent single wavelength of light emitted from certain specialized medium. Now, laser interaction with tissues. If we talk about laser interaction with tissues, how do the lasers interact with the tissues? There are principally four ways in which the lasers interact with tissues. There are four ways of interaction of lasers with tissues. In the first thing, the laser can simply be transmitted. Okay, whatever tissue we are using and firing it upon, the laser should simply be transmitted from that without producing any effect. So if this is the tissue, the laser light is transmitted through the tissue. The second type of interaction can be reflection. The reflection of the laser from the surface. So this is the tissue, a laser light is fired and it is reflected back. The third type of interaction, it can be scattering. Interaction with the tissue can be scattering, means if this is the tissue of interest, we fire the laser and it is scattered in all directions. Scattering. And the fourth is absorption. Absorption of laser by the tissue of interest. A laser light is fired and it is absorbed by the tissues. So transmission, reflection, scattering, and absorption can be the four principal ways in which laser interact with the tissue of interest. Out of these four modes, the maximum usefulness is the mode of absorption. Only when the tissue absorbs the energy of laser will it produce any desirable clinical effect. If the laser light is simply transmitted, scattered, or reflected, there would be no absorption of laser energy. It is only after absorption when we match the particular type of laser with the particular type of tissue. In the oral cavity, if we talk about, we have different types of tissues, the hard tissues and the soft tissues. Hard tissues, if we talk about, they are enamel, dentine, cementum. Okay, and even bone is there. If we talk about the soft tissues, there are different soft tissues like oral mucosa, gingivae, some are keratinized, tongue, etc. There can be pigmented oral tissues, etc. So depending upon the type of tissue of interest on which we have to do the procedure, we have to select a laser, and the laser should be selected whose energy is maximum absorbed. So what is the most desirable effect of lasers on the tissues? The laser energy should be absorbed by the tissues for it to be clinically effective. Now we talk about the classification of dental lasers. The classification of dental lasers. We know that lasers, they are single wavelengths, so they are classified based on the wavelength of light that they emit. Lambda stands for wavelength of light. So lasers can be present in all the three electromagnetic spectrum, means they can be ultraviolet lasers, UV lasers. Ultraviolet lasers for dental purpose, they consist of special type of ultraviolet lasers which are called excimer lasers. Then there can be visible light lasers. Visible spectrum, we all know that is in the range of 400 to 700 nanometers. And then there can be lasers whose wavelength fall in the infrared range. So depending upon the wavelength of light into which they emit the photons, they can be ultraviolet. Special ultraviolet lasers are called excimer lasers, visible in the visible spectrum of the electromagnetic radiation and infrared radiations. Ultraviolet lasers or the excimer lasers principally used for dental purpose are three important lasers: argon fluoride, krypton fluoride, and xenon chloride. They are invisible lasers whose wavelength falls in the ultraviolet region, means less than the visible light. Argon fluoride has a wavelength of 193 nanometers. Whenever we talk about lasers, since they are single wavelength lights, we have to remember the wavelengths. All the wavelengths which I am giving are in nanometers. Krypton fluoride is 248 nanometers and xenon chloride is 308 nanometers. Now we have talked about the tissue interaction. A laser is most efficacious for a particular tissue whose energy is totally absorbed by that tissue. So if we talk about excimer lasers, they are absorbed well by calcified tissues. Means we can say that the hard tissues, the calcified tissues of the oral cavity absorb well the excimer lasers. If we talk about the visible lasers, the important visible lasers, one of the most predominant one is the argon laser. Argon laser is available in depending upon the energy of the source. It is divided into two wavelengths, 490 nanometers and 514 nanometers. Okay. As you can see, this is in the visible region of the spectrum. Then there is KTP laser. KTP laser is potassium titanyl phosphate. Potassium titanyl phosphate, wavelength of 532 nanometers. Then there are different types of diode lasers, which are solid state lasers, mostly in the red region of visible spectrum. Wavelength in the range of 630 to 690 nanometers. These are the predominant visible light lasers. I am again stressing upon that it is important that you have to remember the wavelengths of these different lasers. If we talk about the infrared lasers, the important ones based upon their wavelength, infrared means higher than the visible spectrum. They are carbon dioxide laser, 10,600 nanometer. This has got one of the longest wavelengths in the infrared region, 10,600 nanometers. Then we have Nd:YAG laser. Nd:YAG laser, wavelength of 1064 nanometers. Erbium-YAG laser. YAG stands for, it is a solid state medium. YAG stands for yttrium aluminium garnet. Yttrium aluminium garnet. Okay, it is a solid state medium for the laser. See, the laser medium can be either liquid, solid, or gas. These are the solid state mediums. Erbium-YAG laser has a 2940 nanometer wavelength. Then we have erbium chromium YSGG, yttrium scandium gallium garnet. Erbium chromium, yttrium scandium gallium garnet, which is sometimes also called simply water laser. This laser is also called water laser. Okay, it has a wavelength of 2790 nanometers. Then we have polonium YAG laser, wavelength of 2100 nanometers. Okay, these are the different types of predominant infrared lasers. Out of these different lasers, we have talked about the hard tissue and the soft tissue. So erbium lasers. RBM lasers, they are most efficient for dental hard tissues. So, if we have to talk about the hard tissue lasers, whose energy is absorbed by the dental hard tissues like enamel, dentine, and cementum, which lasers would be the most beneficial to use? We have to select the erbium lasers, and two erbium lasers we have seen. One is waterless, that is erbium chromium YSGG, and another is erbium YAG laser. The second best lasers for the dental hard tissues would be your excimer lasers, which are special ultraviolet lasers. Remaining lasers that we talk about, like carbon dioxide laser, Nd:YAG laser, okay, they are all soft tissue lasers. So if we are operating upon the dental soft tissues like oral mucosa, gingiva, etc., which laser we would choose? We would choose a soft tissue laser. So what is the basic difference between hard tissue and soft tissue laser? We classify the lasers based upon the tissue of interest which absorbs the wavelength of, or we say the energy of laser. So if a soft tissue absorbs the energy of a particular laser, it is called soft tissue laser. On the other hand, if the hard tissue absorbs, it is called hard tissue laser. So this is the principal classification. Another is the delivery mode of lasers. Delivery mode of lasers. Okay. These lasers can be delivered by different means like fiber optic tubes, or they can be delivered through hollow tubes. Fiber optics, as the name indicates, they are thin pen-like fiber optic tubes which work in the contact mode. What is meant by contact mode? Just like we write with a pen, the pen touches the paper. Similarly, we can use small fiber optic tips to deliver the laser by touching the tissue of interest. Hollow tubes, on the other hand, they are tubes with internally lined with mirror so that they reflect the laser and it emits out through the tube. Internally lined with mirror, they are large tubes, so they work in non-contact mode. So some of the lasers work in contact mode, delivered through fiber optic tubes. Some work in hollow tubes. If we have to look for the examples, Nd:YAG laser works in fiber optic tubes. So it has got small tubes which can be literally touched on the tissue of interest, and the laser energy is delivered to the tissue of interest. On the other hand, non-contact modes, prominent example is a carbon dioxide laser. So it cannot be touched to the tissue. We have to fire it from a distance to the tissue. So definitely, if we have to look for the ease of operation, which would be a easier laser to use, which work in the contact mode. Better controlled, more precise delivery of laser is provided as compared to those which are working in non-contact mode. Now we talk about laser applications. In the subject of conservative and endodontics, there are numerous contemporary applications for the lasers. First one we can talk about is caries diagnosis. We all know that caries diagnosis, especially that of an incipient caries lesion, can be quite challenging in the clinical situation. The laser principle that we use is known as quantitative laser fluorescence. Quantitative laser fluorescence. Quantitative laser fluorescence. Okay. And the device that is commercially available is known as Diagnodent. So there is a device which is commercially available called Diagnodent for the diagnosis of caries, and it is based upon the use of lasers that is called quantitative laser fluorescence. We all know that there is a phenomena called fluorescence. When a light of particular wavelength is fired onto a substrate or tissue of interest, it is reflected back in a different color. That is known as the phenomena of fluorescence. So this diagnodent device basically fires a high intensity laser light which is reflected from a healthy tooth as green in color and from a carious tooth it is red in color. So amount of laser fluorescence, the color of the laser fluorescence that we get from the reflected light from the tissue is known as the phenomena of quantitative laser fluorescence. If the tooth is carious, it would emit what type of fluorescence? Red fluorescence. If the tooth is healthy, non-carious, it would emit green fluorescence. So this is known as quantitative laser fluorescence. It is specially used for the diagnosis of non-cavitated lesions. Diagnosis of non-cavitated lesions. Because of frank cavitation which has occurred is easier to diagnose clinically otherwise with other methods. So initial incipient lesions which are non-cavitated can be successfully diagnosed with quantitative laser fluorescence, and the commercial available device is known as Diagnodent. The disadvantage of Diagnodent for caries diagnosis is that it has got low specificity. It is highly sensitive, but it has got low specificity. So there are chances of false positive results. We know that if the specificity of a test is low, it is likely to give false positive results, means it can give a very less demineralization as a frank cavitation, and we can wrongly treat a tooth. So this is known as false positive results. It is highly sensitive, means even a very small incipient carious lesion can be detected with Diagnodent, but it has got low specificity. Okay. It gives a reading. Diagnodent is a device that gives reading in the scale of 0 to 99. Digital reading we obtained from scale of 0 to 99. Another application of lasers in is pulp diagnosis. Diagnosis of the pulpal condition. See, pulp diagnosis basically encompasses two uses of lasers. One is laser Doppler flowmetry, another is pulse oximetry. LDF is laser Doppler flowmetry and pulse oximetry. If we talk about LDF or laser Doppler flowmetry first, it uses helium neon laser. What type of laser it uses? Helium neon laser. Helium neon laser is 632.8 nanometers, which is infrared. Sorry, far, near infrared, which is a near infrared laser. Helium neon laser. Laser Doppler flowmetry basically works upon the Doppler's principle. It works upon Doppler's principle. All of you must have read about the Doppler's principle, that in your school physics, whenever we focus light upon a moving object, the light is frequency shifted and it is reflected back to the source. So if there is a moving object and we fire a laser light onto it, the light would be reflected by the moving object and it would be frequency shifted. That shift in frequency is known as plus shift, and this is known as Doppler's principle. So how do we target the tissues? In laser Doppler flowmetry, if this is a pulp tissue, The pulp tissue we all know is vascular. For a vital tooth, it is vascular. In a vascular pulp tissue, there would be a large number of RBCs moving at high speed inside the blood vessels, RBCs. So, what are the moving objects in the pulp that we are targeting? We are targeting the red blood cells, which are the majority of the formed elements present in the blood. So, if the tissue is actively having blood circulation, it would be having large number of RBCs flowing at very high speed inside the blood stream. So, whenever we fire a laser, that is helium neon laser, onto the tissue of interest, it would be reflected back by the fast moving RBCs and it would be read by a photodetector. This is the working principle of laser Doppler flowmetry. More the vital tissue, more would be the number of RBCs present in that tissue, and more would be the frequency shift of the laser that we are firing on the tissue. So, this is known as laser Doppler flowmetry. Greater the Doppler shift, more vital is the tissue. So, basically, this LDF machine, it measures red cell flux. It measures the red cell flux of the pulp or the tissue. Red cell flux means it is the product of mean number of RBCs present in the tissue multiplied by their mean velocity. This physical quantity is known as red cell flux. So, if in the pulp we are measuring the vitality of the pulp, means more of blood circulation would be there, more of red cell flux would be there, more would be the Doppler shift, and greater the vitality of the tissue. So, laser Doppler flowmetry is one of the most accurate methods to determine the vitality of any tissue or pulp we are talking about. So, advantage, if we talk about, it is the most accurate method of measuring pulp vitality. Why vitality? Because we are actually measuring the blood circulation of the target tissue. Second advantage is it is purely objective. It is purely objective means we do not have to rely upon the patient to interpret the result. If we talk about pulp sensibility test like heat test, cold test, and the electric pulp tester, we have to depend upon the response from the patient to determine the results of the testing and the subsequent pulpal status. Here, this is not the case. It is entirely in the hand of the clinician. If the laser Doppler flow meter shows you greater amount of red cell flux or greater amount of Doppler shift, means it is a vital tooth, and non-vital for vice versa situation. Secondly, or I would say thirdly, the advantage if we talk about it is a non-invasive method of pulp testing. Why it is non-invasive? Because we are not applying any heat, cold, or electric current, so there is no pain to the patient. If I have to talk about the disadvantages of laser Doppler flowmetry, definitely it can be used only on natural teeth. It can be used only on natural teeth. Why? Because if a tooth is having a full coverage crown or restoration, it is not possible to use LDF because the laser light would not penetrate that full coverage crown or restoration and reach the pulp tissue. So it can be used only on natural teeth. If a person is having full coverage crown, what is the best method to determine the pulpal status? It is with a cold testing method like using solid carbon dioxide. Okay, that is the subject for other lectures. Right now, we are focusing upon the laser applications. So you have to remember the disadvantage is that it can be used only on the natural teeth. Secondly, there are chances of Doppler shift from gingiva around the teeth. We all know that if a tooth is vital or non-vital, it is always surrounded by gums or the gingiva, which are richly vascular. So, if we are not isolating the teeth properly from the gums, there can be Doppler shift from the highly vascular gums or the gingiva around the teeth, and it could results to false positive results, isn't it? So, we have to prevent such a situation of Doppler shift from the gingival tissues by isolation of teeth with black rubber dam. We can do isolation of teeth with black rubber dam. If black rubber dam is not there, we can use tin foil to isolate the teeth and prevent the light from reaching the gingiva, or we can use aluminium foil. The second application of lasers for pulp diagnosis is for pulse oximetry. After COVID, pulse oximeter has become a household name. Okay, we all have used pulse oximeter in those years to measure the blood oxygen saturation. So, pulse oximeter basically measures blood oxygen saturation. It is also a method to assess the vitality of the tooth because it is measuring the blood oxygen saturation. Whenever we talk about blood, we talk about the vitality. It is based upon Beer-Lambert law. So what is the principle of pulse oximetry? It is based upon Beer-Lambert law. What is the principle of LDF? Doppler's principle. It uses two lasers. One is a red laser, another is infrared laser. Red laser is of 640 nanometers and infrared laser is of 940 nanometers. Two laser lights are used. So if this is the vascular bed or the tissue that we need to assess the oxygen saturation for, we all know that it is a clip-like device, pulse oximeter. We place it on the fingertip, okay, clip it onto the fingertip like this. Similarly, on one end, there's a device which is firing both red and infrared lights of the respective wavelengths. This is the tissue of interest. Depending upon the amount of hemoglobin present, we are measuring the blood oxygen saturation of the tissue. So blood is present where oxygen is carried by hemoglobin in the blood. So more vital the tissue, more would be the oxyhemoglobin present. So depending upon the amount of oxy and deoxyhemoglobin, the relative amounts of these lights are absorbed by the tissue and the amount coming out is read by the photo detector. This is the working principle. That is like it is a clip-like device. From one end, the lasers are fired. On the other end, the amount of lasers, whether the red is coming out or infrared is coming out, it gives the blood oxygen saturation. This is the working principle. Now, oxyhemoglobin, it absorbs more infrared light. If there is more oxyhemoglobin, more vital the tissue, there would be absorption of more infrared light. So most of the light coming out from the other side would be red light. On the other hand, deoxyhemoglobin, it absorbs more of red light. So depending upon the relative proportion of oxy and deoxyhemoglobin in the target tissue, we get on the other side either the red light if it is more of oxyhemoglobin or infrared light if it is more of deoxyhemoglobin in the tissue, and we determine the tissue to be either vital or non-vital depending upon the blood oxygen saturation. This is the Beer-Lambert law and the mechanism of working of pulse oximeter. If we talk about advantages of pulse oximeter as a test for tooth vitality, definitely it is accurate but its accuracy is less than that of laser Doppler flowmetry. Second advantage is same as laser Doppler flowmetry, that is, it is a non-invasive method of pulpal testing. We do not apply any heat, cold, or current. The third advantage is that it is purely objective. We don't have to rely upon the patient and the response from the patient, whether the patient is in a healthy condition or in a comatose or sedated condition or having a low or a high pain threshold. All these things are immaterial because we are not relying on response from the patient, purely objective. So these are the two principal applications of the lasers in pulpal diagnosis. What are the lasers used? What is the wavelength? I have told you. The second, the third use of lasers in cons and endo is disinfection of root canals. Disinfection of the root canals. In disinfection of the root canals, we use different methods. The first one with the laser application is known as PIPS. PIPS is known as photon-induced photoacoustic streaming of liquid inside the root canal. The technology is PIPS, photon-induced photoacoustic streaming. Okay. Commercially, it is available. The device is available as Light Walker. What is the trade name of the device which uses the PIPS technology or the photon-induced photoacoustic streaming? That is Light Walker. As the name indicates, photon. Photon means light. Which light source we use? We use erbium YAG laser in the PIPS technology. So if this is the tooth that we have to disinfect the root canal system for, this is the root canal system of the tooth, the root canals of the tooth. After gaining access into the pulp chamber, we insert the laser tip. This is the laser tip. Which laser we are using? We are using erbium YAG laser. This is flooded with sodium hypochlorite as the irrigant. So laser tip is introduced only into the pulp chamber and not into the root canals. We fire low energy erbium YAG laser. Because of the energy of the laser, there is agitation of sodium hypochlorite inside the pulp chamber and the subsequent root canals. This is known as photon-induced photoacoustic streaming. There is circulation of fluid inside the root canals, agitation of fluid that increases its cleaning efficacy of sodium hypochlorite. This is known as PIPS. Another advancement in the technology and the latest one, the use of lasers has been sweeps. Okay, this also uses laser, that is erbium YAG laser. The wavelength of erbium YAG laser we have already seen. Sweeps technology is shock wave emission enhanced. Shock wave emission enhanced photoacoustic streaming. Shock wave emission enhanced photoacoustic streaming. So it is using double the energy that is used for the PIPS technology, but you have to remember that both of them uses erbium YAG laser. The second technology or the third technology that uses lasers for the disinfection of the root canals is photo-activated disinfection. Photo-activated disinfection. Photoactivated disinfection. This photoactivated disinfection uses two things. We are talking about the use of lasers in the disinfection of the root canals. Photoactivated disinfection uses one photosensitizer dye. One is a photosensitizer dye, and another is a laser. Some of you must have played the paintball game. Means we spot the target and then we hit the target. Similarly, what is happening? The root canals are laden with numerous microbes, pathogenic bacteria, etc. So before using any laser to disinfect the root canals, what we have to use? We have to use a photosensitizer dye. This dye is injected inside the root canals that would stain or spot the microbes in the first phase. Which dye is normally used? We use toluidine blue. Toluidine blue. Okay. Toluidine blue is also called TBU. The dye that is used is TBU. And the laser we use is red laser in the range of 630 to 690 nanometers, the red region of the visible spectrum. So subsequent to spotting the pathogenic bacteria, we would fire the laser inside the root canal. The energy of this laser is absorbed by the photosensitizer dye. And where is the dye present? The dye is present on the microbes. So ultimately, the microbes get killed inside the root canal due to energy of the laser. We have already seen that for a laser to be effective on a particular tissue, it has to be absorbed by that tissue. And to enhance the absorption of laser energy, we coat the bacteria present in the root canal with a photosensitizer dye, something which sensitizes the bacteria or the microbes present in the root canal to the energy of photons is known as photosensitizer. Numerous dyes are available. Some of the most commonly used ones is toluidine blue dye, which is abbreviated as TBU. This is known as photoactivated disinfection, another use of laser for disinfection of the root canal. Then the third use if we talk about is use for preparation of root canals. Use of lasers for the preparation of root canals. Now, lasers are not very frequently used to prepare the root canals because the laser light travels in a straight line. So if this is the tooth or the root canal that we have to prepare and we insert a laser tip, the light would travel in a straight line and just go through the apex of the tooth without producing any effects on the walls of the root. So to prepare the root canals, a special laser tip is developed. A special laser tip is there. This laser tip is side firing laser tip. Instead of firing from the end, this is a side firing laser tip. Okay, so this is a tip, which is designed something like this. This tip is inserted inside the root canal and it fires laser from the sides and the end is closed. So there is no emission of laser from the tip of the fiber optic. So what is happening? This is known as side firing laser. Example is RC lace, root canal laser, or simply RC lace. Again, which laser we are using? We are using a hard tissue laser, that is erbium YAG laser. We have already seen that erbium lasers are most efficient in removing the dental hard tissues. Whenever we are talking about root canal, we are dealing with the dental hard tissue, predominantly dentine. So we are using a special modified laser tip called side firing laser, and it is used to prepare the root canals and disinfect the walls of the root canals. Then another use of lasers is treatment of dentinal hypersensitivity. Dentinal hypersensitivity is one of the most common conditions affecting the majority of the population. For the treatment of dentinal hypersensitivity. Now, for treatment of dentinal hypersensitivity, we use low output lasers. The low output lasers are used, low energy lasers are used. So these low output lasers, they do not alter the dental tissues. They have got no alteration. They do not modify the dental tissues. They block action potential of pulpal C fibers. We know that inside the dental pulp, there are two type of sensory fibers predominantly present, the C fibers in the center of the pulp and A delta fibers in the periphery of the pulp. So they block the action potential mediated by the C fibers, but not that of A delta fibers. A delta fibers are present in the periphery, but their action potential is not blocked. It is of the C fibers which are blocked. Okay. And once the C fibers are not transmitting, the patient does not feel pain due to dentinal hypersensitivity. This is the working method of use of lasers. What you have to remember, we use low output lasers like gallium arsenide aluminum laser. Okay. Wavelength again of around 630 nanometers. We also use low energy KTP lasers, 532 nanometers. We can also use Nd:YAG lasers. So all these different lasers, which can be visible, infrared, etc., can be used for treatment of dentinal hypersensitivity. Only difference is we use very low energy so that there is no alteration or modification of the tissue. Only the nerves, sensory nerve fibers are done. Okay. This is the use of lasers. And this action of lasers on the pulpal C fibers is reversible. It is reversible. And it is up to 4 months. It is not a permanent effect. After 4 months, we again have to do lasers. So lasers are not very useful. They do not provide a permanent relief from dentinal hypersensitivity, but of course, they can be used in low spa settings. Then the applications of lasers include pulp capping and pulpotomy. See, pulp capping, whether it is mostly direct pulp capping or pulpotomy, that is, we are removing the corneal pulp and preserving the vitality of radicular pulp. Pulpotomy is mostly done in primary teeth or in immature permanent teeth, isn't it? Immature permanent teeth. So, what are the applications in pulp capping and pulpotomy? Usually, we do pulpotomy by different methods, like fixation of the tissue with formaldehyde or glutaraldehyde. Okay, like preservation of the tissue with ferric sulfate, etc., or with regeneration of tissues with MTA and other materials. But all these chemicals and the materials, they have got certain disadvantages, like the cutting of the corneal pulp tissue is not very precise with them. Okay, they leave a pulpal wound, just like if you are putting calcium hydroxide, which is one of the most frequently used agents, it produces a thick layer of necrosis on the pulpal tissue. If we are putting a preservative like ferric sulfate, it has got the tendencies to form a lot of coagulum due to hemostasis present over there. So all these disadvantages, whatever necrotic tissue, coagulum, etc., is formed onto the pulpal tissue, there is the potential to form infection of the remaining vital pulp tissue. So the purpose of pulpotomy, the success of pulpotomy is slightly reduced with these methods. In such situations, we can use lasers. What type of tissues are we dealing with in pulpotomy? We are dealing with soft tissues. So lasers like carbon dioxide laser can be used for pulpotomy. We can use ND-egg laser for pulpotomy. Okay. So what you have to remember that soft tissue lasers are used, and the advantage of these lasers are that no pulpal necrosis. They produce a clean wound. Why a wound? Because we are definitely removing the infected coronal part of the tissue and retaining the vital radicular part. So they produce a clean wound. This is the advantage. So again, the application of laser comes over here. The wavelengths of these lasers we have already. Another is for periapical surgery. Another endodontic application is periapical surgery. Where do we use? We use lasers in the periapical surgery for root end resection. Root end resection. Again, root end resection means we are dealing with hard tissue. So we would be using some hard tissue laser, and I'm again stressing which are the most efficient hard tissue lasers. They are the erbium YAG and erbium chromium YSGG. So both are erbium chromium YSGG. Both of these two, they are the predominant laser types to be used during root end resection. Advantage of using these lasers for root end surgery means first advantage is that they are efficient in removing the hard tissues. Second advantage, if we talk about, is they are very conservative because laser light can travel into very thin dimensions. The amount of bone that is to be removed during surgery to reach the root apex is very less with lasers. They are very conservative. So definitely if we are damaging the tissues to the minimum during surgery, there is a faster and a better healing after surgery done with lasers as compared to conventional methods like, I would say, with a handpiece and burr or with ultrasonic tips. The third advantage of using lasers is that there is no generation of smear layer. Why smear layer is generated? Because we know that whenever we cut the dental art tissues, we are cutting the root end, there would be generation of smear layer. Now, subsequent to cutting the root end and preparing the root end, what would we be doing? We would be putting some root end filling to complete the surgery. Before putting the root end filling, we have to remove the smear layer so an intimate contact between the dentine and the filling material occurs. But with using handpiece and burr or with using ultrasonic instruments, there is generation of smear layer and we need an additional step of root end conditioning before putting the root end filling material. When we are using lasers to prepare and resect the root end, there is no generation of smear layer. Why? Because the laser energy ablates the smear layer. When smear layer is not generated, we can directly put the root end filling material to achieve a better sealing. And there is simultaneous. We are using high energy hard tissue lasers. There is simultaneous sealing of dentinal tibials. Dentinal tibials. Okay, so this is basically what is happening. We have resected the root end with a laser, prepared a small, the cavity would prepared with laser would not be that sharp. would not be that well defined. So these are the dentinal tubules because of melting of hydroxyapatite. Dentine consists of hydroxyapatite 70%. So hydroxyapatite is melted, it flows and seals the dentinal tubules. So they automatically block the dentinal tubules. Just these are the advantages. If I talk about disadvantages of lasers, okay, definitely they are not cost effective. It is an expensive material, expensive instrument to use, especially the hard tissue lasers. They are not cost effective. Second disadvantage, if I talk about, it has a learning curve. It has a learning curve associated. What is meant by learning curve? They are technically difficult to use the hard tissue lasers. We have to be well trained to use the lasers successfully without damaging the other tissues around. Okay. So whenever we are using for root and resection, the extent of resection that is commonly used is 3 millimeters. We resect the root end by 3 millimeters. And if we talk about angle of resection, the use of lasers for periapical surgery, the angle of resection. The angle of resection is usually 90 degrees of flat resection. Okay. So if this is the root for tooth, we are resecting. It is resected like this. 3 millimeter is usually cut off, and flat or perpendicular resection is done. Straight resection is done. This 3 millimeter resection commonly eliminates 93% of accessory canals. We all know that there are structures called accessory canals in the apical one third of the root, and these accessory canals can be the portals for the infected and necrotic elements to be present, which cannot be eliminated with routine root canal procedures. So, if we are not removing or eliminating these niche for the bacteria and other microbes by root and resection, they can lead to treatment failure and subsequent reinfection. So it is important to eliminate these accessory canals. And by apical 3 millimeter resection, almost 93% of the accessory canals are eliminated. And the angle of resection should be flat. That is, it has the advantage like better stress distribution. The chances of root fracture are minimized. Better stress distribution is there. Second advantage is there's very less number of dentinal tubules are exposed. It exposes very less number of dentinal tubules. If we are making an oblique cut, a beveled resection of the root end, definitely the number of dentinal tubules exposed to the surface would be more, and these exposed dentinal tubules all serve as portals of tissue fluid movement from the root canal to the periapical tissues and vice versa. They can serve as apical percolation. So these are the advantages of using lasers in the periapical surgery. Again, I am stressing that erbium lasers, they can be delivered through both contact and non-contact mode. Previously, erbium lasers or other hard tissue lasers were delivered only through non-contact mode, but currently we can deliver them through both contact and non-contact mode, and contact mode is more precise and accurate as compared to other modes. These are some of the applications of lasers in the subject of conservative and endodontics. And currently we are using all these types of lasers. If we talk about Nd:YAG lasers, okay, they are mostly used for pigmented tissues. Pigmented soft tissues like gingiva. Okay. Carbon dioxide lasers only through hollow tubes. So they are less precise. So these are some of the contemporary applications of dental lasers used in the field of conservative and endodontics, starting from diagnosis of both the caries as well as the pulpal condition to disinfection of the root canals to root and resection for the treatment of dentinal hypersensitivity and for direct pulp capping and pulpotomy procedures. Okay. With this, I conclude today's session. See you next month with some other topic. Till then, happy reading. All the best from my side. Thank you everyone for being with me. Thank you very much.